Today I'll be talking about predictive factors for cholecystectomy in bariatric patients who are undergoing medically supervised weight loss. I have nothing to disclose. So rapid weight loss following bariatric surgery is a known risk factor for gallstone formation. Despite this, we currently have no clear consensus on when to offer a concomitant cholecystectomy at the time of bariatric surgery. Our goal is to be able to screen for and to identify patients who are at high risk for requiring a cholecystectomy following bariatric surgery. We note that many patients who've had or are going to have bariatric surgery will undergo a medically supervised weight loss program. Now, this presents a unique opportunity for us. In this study, we strove to identify which patient factors are put you at an increased risk for requiring cholecystectomy following medically supervised weight loss. At the Weight Management Clinic in the Ottawa Hospital, this is a multidisciplinary clinic consisting of physicians, nurses, dietitians, and behavioral therapists. Patients enroll for a full year. 26 of these weeks consist of the dietary portion of the program, which is an OptiFast 900 kilocalorie per day diet of meal replacement, followed by a transitionary period, and then a 1,200 to 1,500 kilocalorie diet of high protein food. At each weekly visit, they undergo 90 minutes of educational counseling, and then following the 26 weeks, they come in monthly for every 6 months. The database was recorded by staff and nurses at the clinic who recorded initial histories, physicals, weekly follow-up reports, and laboratory tests, and input these into a raw database. All results were then verified with patients and corrected for any errors in order to ensure we had the most valid database possible. Between 1992 and 2008, over 3,400 patients were enrolled in the clinic. These include patients who had a BMI of over 35 or greater than 30 with significant comorbidities, including hypertension and diabetes. We excluded those who had a prior cholecystectomy, which was 9.6%, and we also excluded those who did not return following the year-long program, which was 45%. Patients included in the final analysis included 1,561. The median follow-up time was 10.5 years, and median program start to cholecystectomy time was 1.6 years. In our study population, the prevalence of cholecystectomy was 14%. Next, we performed a univariate analysis on selected patient characteristics in order to determine which characteristics were associated with risk for cholecystectomy. On the left column, we see significant factors, which included age, female, hormonal factors, BMI, a rate of weight loss of 1.5 to 2 kilograms per week as compared to a control group of less than 1 kilogram per week, bariatric surgery occurring either during or after program completion, hypertriglyceridemia, prior weight loss program enrollment, and statin use. Interestingly, on the right column, we see the insignificant factors. So these factors were not associated with either increasing or decreasing the risk of cholecystectomy. You'll note that parity is present, and this is traditionally found in most surgical textbooks as a risk factor for cholecystectomy. Similarly, type 2 diabetes or insulin fasting glucose had no effect, nor did the rate of weight loss category ranges of 1 to 1.49 or greater than 2 kilograms per week as compared to the control groups. We next conducted a multivariate analysis, taking all the factors from the significant factors from our univariate analysis. Those factors which had conferred an increased risk for cholecystectomy included females, which doubled the risk, initial BMI. So for every increase in BMI of 5, we found a corresponding 15% increased risk of cholecystectomy, a rate of weight loss of 1.5 to 2 kilograms per week as compared to the control group, and finally, hypertriglyceridemia. Those factors which conferred a protective effect against cholecystectomy included bariatric surgery. Now, this may come as a bit of a surprising result, and it was to us initially. When we consider that most of the patients in our population have their bariatric surgery at the Ottawa Hospital, which has only had a bariatric surgery program for 4 years, this is largely an effect of a short follow-up period. So we expect that if we see these patients over the next 5 to 10 years, we'll find a corresponding increase in the rate of cholecystectomies. Statin use was also noted to be protective for cholecystectomy following rapid medical weight loss. Limitations of our study include a variable follow-up period, which may actually underestimate for the effect of risk factors. So again, if we follow these patients further on in time, we may find that the incidence of cholecystectomy is actually higher. Patients who did not return were excluded, which may introduce potential selection bias. It should be noted that all patients were contacted if they did not return to the clinic within 1 year of the program, and so all those, the database was updated to reflect that information. And we also don't know the effect of asymptomatic gallstones, as we do not routinely screen for this on ultrasound. So in conclusion, multiple risk factors for cholecystectomy were identified in patients undergoing medically supervised weight loss. Predictive factors included female gender, high BMI, rate of weight loss of 1.5 to 2 kilograms per week as compared to controls, and hypertriglyceridemia. Protective factors included statin use and bariatric surgery. Thank you.
Paper open for question. My first question is the rate of weight loss is predictive of cholecystectomy, but the question is that do you really know that these patients already had gallstone from the get-go before they start your program? Because if you don't, then how can you make the assumption that, hey, the rate of weight loss is really the causative for the cholecystectomy?
Right. So it's correct that we do not routinely screen with ultrasound currently for patients enrolling in our weight loss program. So coming into the program, we don't know if they have asymptomatic cholelithiasis or not. So that is something that we are hoping to look into in a future study, but it obviously depends on the funding for the ultrasounds, if we can get that or not.
Regarding the weight weight loss still, I think I saw in there that if the rate of weight loss was greater than 2 kilograms per week, that it was not significant versus the people that lost kind of an intermediate amount of weight. Is that a statistical aberration? Do you have an explanation for that? Is that a small group that lost that much weight?
Right. So those two categories, so people who lost weight between 1 to 1.5 as well as greater than 2 kilograms per week showed trends in the univariate analysis. We suspect that some of that may be due to smaller sample size within our study population. However, there may be other factors that we do not recognize. Perhaps there's a particular profile of patients within that rate of weight loss range between 1 to 1.5 that has a particularly increased risk as compared to the others.
Did those patients differ at all, the patients that lost weight at that really rapid rate versus patients that didn't lose weight quite like that?
Not according to the variables that we looked at, no.
Thank you.
Thank you.
Thank you very much.
I had a question. Could I ask over here?
Oh, sorry.
Yeah, Cliff Black from Anniston, Alabama. I'm a bariatric surgeon myself, and your paper seems to focus mainly on gallstone formation. In my practice, I see 30 or 40% that have biliary dyskinesia, and I wonder if you may comment about that, if that was looked at in your study.
Sure, that's an excellent comment. This paper specifically, we did not look at biliary dyskinesia, so we're purely picking out those patients who had cholecystectomies following the weight loss program, so I can't comment on that.
Great. All right.